Zoom workplace. Good workplace. Okay, okay.
I know that. I work, so you go on that. One time we did have someone have a birthday party at the Costco food court and we gave them aprons to wear and we printed the name tags and that's. Yeah, like. Yeah, a grown man had his birthday party.
I need points for originality, right?
And then like they bought a whole bunch of the like red sport hats. Yeah, that was. Now that I know it's. He really does. I think she's pretty. I don't know, I wasn't there for it, but there's pictures of it. Oh, no. Oh, this is. They all dropped out. It's like, it's like a lot. Last week, we only have 5 more classes of pharmaceutics left.
Woohoo! How is that possible?
I found it yesterday.
It's only twice a week? Oh. Oh. What else do you guys have this week? Nothing?
We have a mic.
You have
Oh,
two
and
quizzes.
drug quiz, but drug quizzes, but I've never taken one of them.
Who gives you that quiz? Because I can pass that information on.
I do. I take it seriously, but it's like, it's not like you have to like, it's not. Like,
Mind-bending
yeah.
information.
10 questions or 15 questions. You know, it's actually pretty nice.
What do you guys think of the exam yesterday? It was good. I felt like I tried to really write the exam questions to align what we discussed in class.
My question made it.
Wow. Which one was it? Ah, yes. Actually, I think there might have been like 7 total student questions because some of them were like I specific. So I was like, oh, I'll just slip it in for my I questions too. But yeah. Okay, well, I haven't graded them yet. I'll be honest with that. I'll probably get to it this afternoon. I would love to have like a quick turnover. Once I return your physical exams to your box, I'll be putting them into those envelopes that are in there. And so if you see that envelope, you can just check in there for your returned exam. Okay. You're looking like him.
Wondering what the envelope is for.
Just to keep anonymity amongst exam scores, just because we want to make sure that like only you see your exam score. So that's what the purpose of the envelope is serving.
Is it just for this?
No, that should be for all the, yeah, that might be the protocol moving forward. So all of your respective classes will probably be returning to the envelope. Yes. So once you take your exam out of your manila envelope that's in there, just leave the envelope in there. That's how we'll be returning exams, just to make sure, again, your score is only for your eyes and If you choose to show it to other people, then so be it, but we just want to protect your anonymity or your scores. Yeah. Okay, other questions or concerns right now moving forward? I guess we just had an exam, so really no content questions. But today we'll be making our transition from autonomic nervous system to cardiovascular system. So I handed out everybody a piece of paper to start class. So I'd like you to take that piece of paper and fold it in half.
We're doing hot dog or meatball?
It doesn't matter, whatever you prefer. I would say hamburger probably would give you a little bit more working space for this exercise. So yeah, I'd say go hamburger versus hot dog. But you can probably make it work. This is hot dog, or this is hamburger, this is hot dog. Sure. Yes, I want hot dogs. Okay, so choose one half of your folded piece of paper, and we're gonna do this kind of like a mind dump. Okay, concept map, mind dump. When I say cardiovascular system or the heart, what do you think of? What is your past experience? Like, if you take an AMP, then so be it. I know a lot of folks are just like, do not assume irritate anything from AMP, so that's fine. When I say heart, it can be just very open. It can literally be song lyrics or the band Heart, but just like on that cardiovascular side, anything heart conceptual that you think of when I say the word heart or cardiovascular system, just go ahead and concept map that out on one of those sides. So I'll give you guys probably like 5-10 minutes to see kind of how things go. I would say start individually, and then maybe as you get all of your own brain dumps, feel free to kind of share your information with people sitting next to you. Maybe you can kind of continue to grow it out of that concept. Okay. You can draw things, it can be a picture, it doesn't matter. It's just kind of, again, any information that comes to mind when I say heart/cardiovascular system. It can be keywords you remember. There you go.
I didn't know much. Oh, I was thinking I was organized. First.
Yeah.
See, that's a pretty good word.
We should at least have some receptor knowledge, right? A little bit, we talked about some receptors that are expressed there.
Oh, yeah.
Remember the adrenergic receptors, baroreceptors that are found in the aorta? Give me answers. Aorta. Keyword you throw out there. Like, how many chambers are there? What divides the chambers? What are the names of the chambers? See, the more we talk about this. What tissue types do we find at the level of the heart? Receptor types, heart physiology, disease states related to the heart. Do you know any disease states related to the heart? See, these are all things that you already know before we even start lecturing. That should give you confidence. Right?
Fun fact, my grandpa's had 3 heart attacks and has been struck by lightning twice. And that means it's
Still alive?
still kicking.
Oh my gosh.
Yeah, and so one of the top like
I would say don't go all to the bad dude.
Oh, no.
Like, give him a little stick, the range, or go away. Okay, how's everybody feeling?
What's the like QT prolongation for over?
Ooh, there you go.
Yeah.
Yeah. Yeah. Stroke volume, cardiac output, vascular resistance, hypertension. Okay. Preload, afterload. Okay. So you guys have just kind of mind dump onto that piece of paper. Hopefully that doesn't necessarily overwhelm you. It gives you maybe a sense of confidence in what we're about to talk about. And the purpose of the next couple lectures are just really to put all of those terms or drawings or whatever you said into kind of an organized context. Here's our study guide for this particular lecture. However, the how does the ANS interact with the heart really is going to be kind of like the front end of this lecture, and then we'll come back to revisit it a little bit later, just because I pulled those slides that we didn't finish for ANS and put them at the top of this lecture. So we'll talk about receptor expression at the heart, and then we'll talk about a few choice medications that interact with that system. Okay, so here's our pre-lecture quiz. I'm going to kind of continue to fly through this. This is always like a really nice way to self-assess your acquisition of information. I will say I went back and looked through our pre-lecture quizzes, and some of you just pulled your questions right off of the pre-lecture quiz. I was like, these look really familiar. Okay, so when we talked about the autonomic nervous system, like I said before, this is kind of like a beautiful transition from like, we talked about the nervous system, some concepts of the nervous system exist within the autonomic nervous system, and the autonomic nervous system is directly related to the cardiac system. And so we did already kind of cover this slide, but I like it because again, this is hopefully should be a comfortable place for you, where we talk about the parasympathetic and sympathetic effects at the level of the cardiac tissue, right? We know this now. We know with parasympathetic innervation, you know, that vagus lowers heart rate, with sympathetic reflex via cardiac accelerator nerves causes that heart rate to increase. We can also see again the placement of those baroreceptors at the level of the carotid baroreceptors, as well as those baroreceptors that exist on the aorta, to give you information about the blood pressure. And again, the heart can create a feedback loop mechanism to kind of regulate that as such. Okay. So we talk about blood pressure. What happens when blood pressure increases? Again, we covered this last time. Baroreceptors. What activates a baroreceptor? I've heard some folks maybe say it. Okay, so far when we've been talking about receptors, we've talked about G-protein coupled receptors and ionotropic receptors. Are baroreceptors either of those? No. What kind of receptor are they? They are a stretch receptor, right? And so what activates them is the stretching of that actual like ionic protein structure. So when blood pressure increases, you see an increase in action potentials from those baroreceptors because they are opening up, okay? They're allowing for an influx of sodium, and that's what's leading to an increase in action potential generation. So just keep in your mind, baroreceptors, kind of their own special type of receptors, and the fact that they're stretch receptors, and they tell us whether that blood pressure is actually increased. So you're getting that activation of the depressor center that's part of the caudal ventrolateral medulla, and also synapses with those preganglionic sympathetic neurons that are going to lead to that negative feedback loop system and actually inhibit their contraction components. So it's decreasing the heart force and rate of contraction to decrease vasoconstriction of blood vessels. So this is part of that feedback loop system. Baroreceptors are stretching, saying and firing at a high rate, saying, hey, this is too high. Let's start to decrease our, things like force and rate of contraction, and that helps bring blood pressure back into homeostasis. Versus when blood pressure decreases, so if you have, let's say, a major injury, you're losing a lot of blood, a hemorrhage is an example of that. If you had a hemorrhagic stroke, baroreceptors decrease in the number of action potentials. So again, you've got more of those baroreceptors that are staying closed. And so you might have like a kind of open state, homeostatic state, where you have some baroreceptors that are open. But if you have a decrease in blood pressure, those, homeostatic receptors are going to close, and that's going to indicate a decrease in blood pressure. So it's going to stimulate your preganglionic sympathetic neurons. Okay, So the sympathetic nervous system, what does that do? It helps to increase your heart rate, your force of contractility, right? Because we know it's that fight or flight response. And so it increases heart rate and force of contraction to the blood vessels to constrict. So this is, again, the way our bodies are able to respond to either elevations in blood pressure or, a lack of blood pressure or hypotension. And there's a lot of pharmacological targets here, unfortunately. Like this is, I don't want to say an oversimplification, but it's good to know what the normal homeostatic process is. And we'll talk about pharmacological agents that can modulate this a ton when we're talking about them in Pharm Talks. We'll talk about a few today, but just keep that in mind. Understanding that feedback loop mechanism is quite important. The baroreceptor reflex, again, we've already talked about this a little bit. You've got those baroreceptors at the level of the aorta, as well as the level of the carotid artery. Because they are stretch receptors, they are sensing, again, mechanical changes or stretch changes that occur in those two regions. So as you see an increase in pressure in your carotids at the level of your aorta, that's going to send information back to either the parasympathetic or sympathetic nervous system, and they're going to be able to bring that cardiac rate of force and rate of contraction back to, again, either increasing it to offset hypotension or decrease heart rate and force of contraction in the case of hypotension. Okay, so yes, this is kind of, again, a graph just showing us the kind of mean arterial pressure here. Those baroreceptors are sending information up into the vasomotor center, and that vasomotor center that's located in the medulla is going to project either to the parasympathetic or sympathetic nervous system, and again, affect the heart rate and response of this. Also keep in mind, outside of this mean arterial pressure, you also have a hormonal feedback loop that's also sensing like peripheral resistance. And so renal blood flow or pressure is also being detected consistently. And so renin and angiotensin and aldosterone are kind of the hormones that set up a signaling feedback loop system here. These are all part of the RAS system. Okay, so you guys have probably heard of angiotensin receptor, agonists, or ACEs, your ARBs, right? Hopefully these are not completely foreign concepts to you, but if you've heard of those drug classes while working in pharmacies, that's kind of focus on targeting this hormonal feedback loop system here. So from like hypertension, vantage point, there's several different places that you can pharmacologically target this. Hormonal feedback loop system is one of those. And then you can also affect contractility force, venous tone by targeting things like our adrenergic receptors or our calcium, right? You guys have heard of beta blockers. You've probably heard of calcium channel blockers. That's going to be targeting kind of the top part of this figure. And like I said, our ACEs and our ARBs are kind of focused on hitting this bottom part. But this isn't Pharm Talks, so we don't need to get in the weeds there. I'm just kind of letting you know that's where those drug categories or those drug categories are going to be acting at to alter blood pressure. Okay, so targeting the ANS via cardiovascular system. This is just nice because, again, it breaks it down into beta adrenergic receptors, centrally acting sympathoplegic drugs, postganglionic nerve terminal blockers, alpha-1 selective adrenal receptor blockers. Okay, the purpose of this is not to make you memorize these respective drugs yet. We will get there, so it's not a huge waste of your time to start to familiarize yourself with brand generic and kind of which categories they fall into. Hopefully, it also gives you some indication as to, again, why we're spending so much time talking about ANS and the cardiovascular system kind of hand in hand. This figure is nice because it does also kind of show you the actual like pathophysiology and like the actual structures that are being impacted here. We have our vasomotor center. We have methyl-dopa, clonidine, guanfacine, our sympathetic nerve terminals. Again, we have a couple different drugs that also target there, one of them being reserpine, which we did talk about a little bit when we talked about the release of catecholamines and how reserpine blocks the vesicular transporter. It's like, hey, full circle moment here. We're actually still talking about nervous system stuff. We've got beta blockers that block the beta receptors of the heart, your alpha receptors of the vessels, angiotensin receptors of the vessels. Also, you have angiotensin receptor blockers. Okay, should probably stop talking about this slide. Again, just trying to show you the big picture of where we're headed, talking about all of these different receptor systems and how we can either block or agonize them to have the intended cardiovascular effect. Because as many of you know, having worked in pharmacies, these classes of drugs are dispensed quite frequently because we do have a lot of cardiovascular diseases, especially in our elderly populations. Okay, so beta blockers are used to target the autonomic nervous system. So here we can see an example drug, propranolol. If you guys remember, that was a drug that I was told to take. Propranolol, you can see contractility, force, or arterial pressure, heart rate. This is, the exposure of epinephrine. Once you apply propranolol, that acts as a beta blocker and basically antagonizes that epinephrine or competes for it at that same site. So you can see that cardiac contractility force kind of completely dissipates. And then you can see that some of the effects for the arterial pressure and heart rate as well. That heart rate goes way down. This is just giving you a table of several beta blocking receptor drugs. One, again, you do not need to go into this to focus on all of these yet. Keep in mind, propranolol is considered a non-selective beta blocker, meaning that it blocks both beta 1 and beta 2. And as you look for these beta blocker receptor drugs, you do see some that are beta 1 selective and some that are non-selective. Okay, and since beta 1s are expressed on the heart, there's a higher degree of specificity, so you might see fewer side effects with your beta 1 selective versus your non-selective drugs. Okay, and again, I'm just trying to avoid really going into the weeds here, so let's just talk about a few examples. And again, this is kind of giving you a taste of what Pharm Talks is going to be like, but we won't sit here too long. Okay. So nalidolol is going to be a non-selective blocker, blocks both beta 1 and beta 2. It's orally administered, non-selective, a beta receptor antagonist. So when we talk about beta blockers, we're really talking about a drug that antagonizes the beta receptor. Now, in this class, we haven't really, I guess, I've verbally described this, and I'm just going to do it again today, the difference between an agonist and an antagonist. An agonist is going to be something that mimics the endogenous ligand's action, right? So an agonist is going to bind to that receptor and cause kind of the same downstream effects that would normally occur if the endogenous ligand was there. An antagonist will bind to a receptor and usually compete with your endogenous ligand and kind of block the effects that normally would happen. Now, those are probably the two most commonly used mechanism of action of drugs, agonists and antagonists. But next semester, we get to talk about things like positive allosteric modulators and negative allosteric modulators, which are actually really cool and some of my favorite classes of drugs. And we have talked about positive allosteric modulators like our benzodiazepines, right? They do not bind to GABA receptors and activate them. They bind to a secondary site, and then they increase kind of the efficacy of signaling of the endogenous GABA. Okay, so let's leave that here now. Okay, so these beta blockers act as antagonists. They'll go ahead and block sympathetic stimulation mediated by those beta 1 receptors of the heart and vascular smooth muscle. And this results in a decrease in both resting and exercise heart rate and cardiac output. So with your beta blocker, what you're doing is you're kind of decreasing your sympathetic tone. Okay, so your sympathetic tone is fight or flight, right? We'll go full circle here, fight or flight, which does things like increases your heart rate. And so with a beta blocker, you're kind of blocking your body's response to sympathetic tone a little bit. Well, I'm painting it with very broad strokes here. So this is used for hypertension, which makes complete sense, right? Like normally, if you're in fight or flight mode consistently, you're putting a ton of you're putting a ton of stress on your heart, trying to pump out that blood consistently in response to that fight or flight response. So this helps mitigate this. 2007 AHA guides of the management of hypertension, beta blockers should not be used as first-line therapy for treatment of hypertension. Usually what we'll use for our first line is kind of our sodium blockers, our thiazide diuretics. Usually the diuretics are one of the first things that we go to. But depending on the population, you might also see those ACEs and ARBs used for hypertension as well. Let's see. So these guidelines do, however, recommend the use of beta blockers for treatment of hypertension in patients with angina, also used to prevent heart failure. So it's not just necessarily hypertension, but if your patient has some of these additional comorbidities and you're worried about vascular health, using a beta blocker can be pretty effective. Might be used to reduce reflex of orthostatic hypotension, and might also competitively block beta 2 adrenergic receptors in response to bronchial smooth muscle, potentially inducing bronchospasm. So those are kind of some additional things to consider. Now, the next slide, again, indicated uses are angina, again, angina we haven't really defined yet. So it is chest pain caused by reduced blood flow to the heart. Okay, so on your piece of paper, okay, you've got your word map on the one side. On the other side, I think we should start to maybe make a list of cardiovascular disease states because a lot of them are like just shortened nomenclature. They're so it's good to kind of start to keep track of those things. So let's just start with angina. Again, angina might not be a word that's part of your vernacular. So saying angina, chest pain caused by reduced blood flow to the heart. Again, if this isn't a word that you're used to, as you're getting more comfortable talking about cardiovascular disease states, that might be one that you would use. That makes sense, right? Okay, so when we talk about side effects, this is one of those reasons that we spend so much time talking about where these receptors are found and how you could have non-specific effects of sometimes of the drugs that you use. And so most adverse reactions are manifestations of its therapeutic effect because beta blockers depress myocardial contractility, might precipitate or exacerbate congestive heart failure, especially in students or in patients with systolic dysfunction. And we'll talk about systolic dysfunction a little bit later on. Abdominal pain, bronchospasm, colitis, constipation, cough, dizziness, fatigue, nausea, flatulence, and hallucinations all could be possible side effects of this. And keep in mind, all of those physiological systems where you're experiencing these side effects also have beta receptors. That's how it exerts these side effects, right? Because you're possibly blocking these receptors at other areas of your physiology that aren't necessarily where your intended therapeutic effect is supposed to take place, okay? So absolute contraindications here. What is a contraindication? Don't do it, basically, right? These are instances that you should not be like dispensing or prescribing drugs to these patients. And so individuals who have asthma or AV block or bradycardia or heart failures in some of those patients, again, absolute contraindications, do not dispense to these patients. That's kind of what that's telling you. Asthma, why? Bronchospasms, right? And if they're asthmatics, what other drug could they be taking that also targets the beta receptor? Albuterol, right? And what does albuterol do? It's a what? It's an agonist for the beta 2 receptors, right? So remember, beta 2 receptors activation in the lungs is good for asthmatic, but if you start to antagonize those receptors, not great. Okay, so this is again one of these reasons that we teach you this stuff is so you can start to reason through these agonist versus antagonistic interactions. Does that make sense? I'm seeing like a little bit of scowling, being like, let me wrap my head around this. Yeah, albuterol activates those beta 2 receptors, and nadolol is going to antagonize or block those receptors. So if you have asthma, not great. Okay, so targeting the ANS and cardiovascular system, keep in mind, here we have our alpha receptors, and much like we see with our beta blockers, you can also have particular agonists or antagonists that have a higher degree of affinity for one subtype over the other. I don't know if we've defined affinity, but it's kind of like, you know how you have an affinity for a person, right? There's some people you really like. There's some people you don't care for. Drugs are the same way. They have receptors that they bind more tightly to. That's how we assess affinity. And then there are some receptors that they just might slightly tickle, bind to for a second and then unbind, okay? And so in this case, we can see, for example, just the degree of affinity for one of those receptors over the other. You can see some are more selective for alpha 1 over alpha 2, and some of them have the same degree of affinity for both of those. So let's talk about alpha 1 versus alpha 2 drugs. Okay, so prazosin is going to block alpha 1, but not alpha 2. What does that mean? Where are alpha 1 receptors found? Postsynaptically, right? Alpha 2 are found presynaptically. We're blocking that postsynaptic effect of those alpha 1s. We often see it's an oral agent used to treat hypertension. It's sparing those alpha 2 receptors, so it does not activate norepinephrine release, and in turn has a lower incidence of reflex tachycardia. causes peripheral vasodilation by selectively competitive inhibition of vascular postsynaptic alpha-1 receptors, thus reducing peripheral vascular resistance and blood pressure. Okay, so we're really not even acting at the level of the heart too much here. We're focusing more on our peripheral systems, and we're antagonizing or blocking the effect that we would otherwise have, causing that peripheral vasodilation. So vasodilation versus vasoconstriction. So in terms of blood pressure, it's easier if you've got that wider pipe, aka your vascular system, for your blood through to flow through versus a smaller pipe, or your vascular system, which would increase the amount of pressure, or that is again a relative thing of hypertension that causes hypertension to occur. So your peripheral vascular resistance kind of decreases with this particular drug. Okay, side effects, you might see dizziness, headache, drowsiness, fatigue, weakness, most frequently reported to adverse CNS effects during treatment. Keep in mind our adrenergic receptors, many of these are kind of peripheral effects, but we do have adrenergic receptors in our brain as well. And if these drugs are permeable to the brain, that's when you might be able to pick up some of the CNS side effects associated with these drugs. They can be alleviated with a decrease in dosage or might resolve on their own. Less frequently reported CNS effects include vertigo, depression, nervousness and anxiety, paresthesia, and hallucinations. So if you were to look at the structure of this drug, this is again one of the reasons that you guys are going to take medicinal chemistry, is so you can look at the chemical structure of a drug and say, okay, is this drug hydrophobic or hydrophilic? Why does that matter? Yes, distribution and its ability to pass through membranes, aka like the blood-brain barrier. So I'll be honest, I don't know the structure of this drug, but if I had to guess, I bet you it's a little bit more hydrophobic, kind of lipophilic, and is able to get across that blood-brain barrier quite easily because we are seeing CNS side effects associated with this drug. Okay. Let's see, insomnia has also been reported. And again, that sometimes this therapy has been associated with worsening of pre-existing narcolepsy. However, a causal relationship has not necessarily been established. Okay, so this is alpha-1 antagonist. So alpha-2 agonists. So why is it that we would antagonize alpha-1, but agonize alpha-2? Yeah, exactly. So they're having kind of two different effects because alpha-2 is found on the presynaptic side, and it's going to reduce further release of the neurotransmitter, versus alpha-1 that's found at the postsynaptic side. If you're blocking that signaling, again, you're going to reduce this downstream side effects or the downstream effects of that receptor. So we do see quite a few alpha-2 agonists. We haven't, clonidine is one of those. It decreases CNS sympathetic tone to cause vasodilation. And again, we're talking about many of these cardiovascular diseases, when we're talking about hypertension, we more often than not are we're trying to decrease the sympathetic nervous system. We're trying to mitigate that fight or flight, okay? Because when we activate fight or flight, that's going to endogenously lead to an increase in heart rate and contractility and an increase in blood pressure, okay? Because if you're trying to evade an animal, your body needs to be able to respond with that kind of increase in cardiovascular tone. So let's talk about clonidine. It is, in fact, an alpha-2 agonist used transdermally for the treatment of hypertension, orally for the treatment of hypertension and ADHD, as well as an epidural agent for refractory cancer pain. It's an agonist at those presynaptic alpha-2 receptors in the medulla, specifically in the nucleus tractus solaris. And this is just the depressor area of the vasomotor center. Again, this is probably one of the important points. I would maybe highlight this on my slide if I were taking notes here, is that the stimulation of these receptors results in the inhibition of sympathetic outflow and tone. As I just said, you're kind of just trying to depress that whole fight or flight experience. And so because of that, you're decreasing vascular tone of the heart, kidneys, and peripheral vasculature, lowering that peripheral resistance, and thus reducing blood pressure. Okay, with that in mind, right? Alpha-2 receptors are found in a lot of different areas of our physiology. So what does that probably mean in terms of side effects? A lot. Holy cow, our side effects here. You can have, interestingly, a faster pounding heartbeat or a very slow heart rate, feeling short of breath even with mild exertion, rapid swelling, weight gain, confusion, hallucinations, flu symptoms. Again, I'm not going to read through this whole thing, but it gives you some insight as to like how many different areas that you might find the alpha-2 receptor. Okay, I've been yapping at you guys for about 30 minutes, so let's just take a little like break, intellectual break here. Okay, you guys, do you have anything you'd like to add to your pieces of paper? You're like, no, you're like, no. What I might add is kind of, again, we've hit upon it previously, is that alpha-1 versus alpha-2. We should, by this point, you guys knew it was going to be on the exam yesterday, where they are found, and how alpha-1, when you're targeting this for cardiac, you want to use a alpha-2 agonist or antagonist? Agonist. You want to use an alpha-2 agonist because that's presynaptically found. You're going to reduce the sympathetic tone. And then alpha-1 agonist or antagonist? Antagonist. You're going to want to block that alpha-1. Okay, that's going to inhibit that further sympathetic tone being sent. Okay, I feel like today's lecture has been kind of dense so far. So let's go ahead and stand up. Find somebody that you maybe rarely talk to in the class. And my question of the day for you, what makes your heart happy? What makes your heart happy? Interpret that however you like.
Let's go that last thing. Is so for the alpha-1 agonists, those target
Oh, an antagonist.
antagonists target the I'm losing it. Do they target the alpha or beta receptors?
Alpha-1 would target the ag or the alpha receptor. Yep.
And that is targeted by the antagonists. So are host receptors targeted by antagonists and pre-receptors?
It's not, you can do
Either one.
either one. Yeah, let's draw it really quick. So here you have the cell releasing, and this is gonna be your alpha.
For one.
Okay, and this is gonna be your alpha. Okay, so if you want to decrease this downstream signaling, what do you want to do to this? You want to
Antagonize, like inhibit.
yeah,
Okay.
antagonist, yeah. And then if you, let's say, antagonize this, since this is inhibitory, if you activated this, what's going to happen?
Activate it for and then it would stop.
Yeah, so you're going to see
Oh, I
reduction.
see.
Yeah, so
Okay.
here's the thing. You can't simplify this to like agonist free or agonist free. You could antagonize or agonize either receptor based off of the structure.
But it matters if they're inhibitory or excitatory.
Yeah, it depends on what the downstream effect that you want to have. So if you said you had a hypotensive patient
Yeah.
and you wanted to elevate their blood pressure, then you could antagonize this receptor or agonize this one.
Okay.
And then that would lead to,
Oh,
does that make sense?
that does make sense. Yes.
Okay.
Yeah, that makes
Okay. Yeah.
Yeah, I'll be right back. I got something caught in my throat.
No, don't worry about it. Ooh, ooh, ooh. Let's see, can I do it? Wasn't that hard?
Another sharp.
No, I'll bring my own next time. How do I turn my light on? Okay, let's go ahead and have a seat. Okay, what makes your guys' hearts happy?
My bed.
Your bed?
Naps.
What'd you say?
Naps.
Naps?
Chocolate.
Paydays?
Yeah.
What is that?
It's energy drink.
Energy drink?
If I have 6 or 7 of them, it really makes my heart out.
Oh my God. We'll have to have a conversation about adenosine receptors at some point in time. Okay, one of your classmates just asked me a quick question and I drew a picture up here and I thought, hey, this picture seems kind of helpful and a good synopsis of what we just discussed. So I'm gonna put it up here. This is my first time with the doc cam. So we'll see how this goes. Okay, and this might also not be a terrible thing to also capture on your paper too. And it might just make this a little easier to understand. Okay, so we have a presynaptic cell, we have a postsynaptic cell. Where do we find our alpha-1 receptors? Post 1, 2, 3, 7, alpha-1. Okay, and those are going to be coupled to G-alpha, S, and Q. So that's kind of excitatory, for lack of a better term. Alpha-2 are found 7. So alpha-2, and that's found 3, and that's going to be alpha coupled to G-alpha I and O, which is essentially inhibitory. And I'll just put, there we go. Okay, so if we activate alpha-1, again, we'll say activation of sympathetic. What would happen? We would see increased release of neurotransmitter here and lots of activation of alpha-1, right? And so that would lead to downstream activation of that target tissue. Okay, so increased sympathetic, this gets activated. And that leads to downstream increase in heart rate and contractility. Okay, so let's say in the case of hypertension, in what ways could we modulate the system that we just talked about? So what will we try to do to alpha-1? Antagonize it. So we're going to block it. So we're going to apply an antagonist. Sorry, that's an N and that's an I, an antagonist. And that's going to block the alpha-1 receptor, and that's going to block that downstream sympathetic tone. Okay. Now, because presynaptic alpha-2 is inhibitory, how do we want to pharmacologically target that? Agonize. We want to agonize it. And that would lead to, again, activation of this, but it would lead to decrease in presynaptic release, and the downstream sympathetic tone would be less as well. You guys are like, your handwriting is atrocious. I know, I will work on it if we're going to do more drawing. Does this help? Okay, which drugs did we just talk about that fall into these two categories? What does clonidine do? Okay, and then what was our alpha-1 agonist? Yeah, like, I just want to make sure I spell it correctly. Yeah, PRAZ. Okay. You guys like this? More than me drawing on the board. It's probably a little easier to see, okay? But it's a good synopsis of what we just discussed in terms of like mechanism of action. Okay, I'm gonna flip back to the regular PowerPoint. Does everybody get able to capture this? Okay. Come away. Oh, new toy to play with. This is exciting. Okay, you guys are gonna be like, no, less drawing. Okay, now the other mechanism of action we'll quickly talk about here. Oxybutynin is just a muscarinic receptor antagonist. Does not appear to affect smooth muscles or blood vessels. This is often indicated or used for patients with neurogenic bladder. having a lack of bladder control. And so this isn't necessarily cardiovascular in its target. A bladder muscle relaxant, it suppresses the urge to void, and then inhibits the involuntary detrusor muscle contractions caused by detrusor muscle instability. Again, if that's non-neurogenic, or detrusor muscle hyperreflexia, because of that neurogenic disorder. So it just kind of depends. There can be various different etiologies that lead to, again, this urgency to void and lack of bladder control. And so in this case, you're seeing the detrusor muscles are mediated by M3 receptors. Ooh, M3 receptors, excitatory or inhibitory? Excitatory. So coupled to that G alpha S and Q. So again, the mechanism of action here is a non-selective antimuscarinic agent. So the side effects are consistent with any anticholinergic actions in the CNS, parotid, and GI tract, and this possesses kind of local anesthetic properties as well. Now, we just said it is non-selective, so it's going to hit a lot of different systems. The side effects: hot and dry skin, severe stomach pain or constipation, blurred vision, eye pain, or seeing halo around lights. We do have cholinergic receptors in our eyes. And that's part of what can lead to dilation and contraction. We didn't go into like the use of some of the agents that are used for that purpose in the eye. We'll talk about that more in Pharm Talks. Dry mouth, dry eyes, blurred vision, mild constipation, diarrhea, nausea, dizziness, headaches, sleep problems, and runny nose. Again, lots of side effects here. What I'm telling you that this particular drug is non-selective. So if we wanted to create, in a hypothetical world, a drug that had fewer side effects, how could we do that? Use a selective drug, right? And so I think that's honestly where pharmacology is kind of going to head, is we're going to see more drugs in the market, but those drugs are going to be more selective for the receptor subtypes at those specific tissues, okay? So again, that's one of the reasons we talk about what receptors are causing the dysfunction in homeostasis. And if you can create a specific drug that targets it, you start to mitigate some of the side effects associated with it. Okay, so that's kind of the end of our drug reflection. So now let's start very basic with the heart, okay? Fun little activity. Not often are you told to take out your phones in class. Take out your phone. You guys are like, what? You're telling us to take out our phone? Take out your phone. QR code. Just want to make sure it works. Hopefully my head's not stopping you. Yeah, so it's just going to show you a picture. Oh, I wonder if I can go back to this thing and show it to you on this. I know. If I can get the. Okay, if you weren't able to take out your phone, this is actually what shows up on your phone. So it's just kind of a fun way to study. And so this is what I'm going to have this do for the last 5 minutes of class. Recreate this on the other side of your paper. So now that we have an anatomically, well, oh, that's beautiful. You draw that?
I didn't, like, I just looked at it.
Still, that takes a certain amount of artistic. If you need another piece of paper, I can share another piece of paper with you. No. And this doesn't have to be an artistic exercise. But I think as we move forward to talk about how the system works, knowing the structures will be helpful. Because when I start to talk about all of these different structures, I want you to be able to have at least a little bit of a picture in your mind as to what we're discussing. And if this is something, a particular topic you're really comfortable with, that's great. You can start to talk about the steps in the contraction cycle. What happens when? Sorry, I'm just giving you guys paper. I don't think we don't need it anymore. You think you're good?
No, we're good.
You guys good? So yeah, so make sure you label most of what you see on here, because tomorrow what we're going to talk about is the contractility cycle, what happens at each step, what's loading, what's after loading, what pathophysiology is related to each of these structures.
You should. I
like should.
Yeah.
Good. Yeah.
You should have just like. Don't give us the,
I'll give you a word bank.
I was gonna say like, just don't give us the. What's that thing called? The picture, just like be like,
Word bank to draw it.
word bank and like, put them relatively where they go. You know, like,
Oh, like in a situation of this.
oh no, that's. Like,
Yeah, but that's not necessarily assessing your knowledge of matching one to the other. Stick assessment. So tomorrow, I think what we'll do is we'll go over, like, again, kind of basic cardiac structure, the process of contraction, and then, maybe on Thursday, we'll kind of do a dry lab situation. 'Cause there's some pretty cool anatomical, software out there that I kind of like to bring into the class, so, but, I'll look at it before I actually bring it in here, it's gonna be dependent on how we're moving through the material too. Do you guys have any questions or concerns today? No. Well, if you do, good luck with your rest of your Tuesday. It's supposed to be beautiful today, so when if you get a chance to go outside and smell fresh air, by all means, do it. It's gonna be like 66 today. Cool. Okay, good luck with your quizzes. I'll see you tomorrow. Yeah.
you're gonna do this.
And then I drew a picture of